Hey everyone, welcome to the Neonatal Cardiac Curriculum Series. Today we're going to be reviewing left to right shunts. For CME purposes, the presenters have no disclosures or conflicts. And so today's goals, we want you to understand the pathophysiology and significance of left to right shunts. We want to know the different types, as well as the key differences in magnitude, how to determine the direction of shunting, as well as which chambers of the hearts that are usually affected. And then we want to review the specific lesions. Specifically for this talk, we'll go over ASD more in detail, VSDs, as well as AVSDs. We'll review the pathophysiology, the natural history, and then how it impacts the management. So in terms of a review real quick to fetal circulation, it's helpful to understand the pathophysiology of left to right shunts by understanding fetal circulation. So just to recap, in the fetus, there's oxygenated blood that's delivered by the placenta. It's delivered via the umbilical vein through the ductus venosus as it joins the IVC. So this well-oxygenated umbilical venous blood, typically around 85%, is preferentially shunted through a eustachian groove or a eustachian valve, which helps to channel that blood across the PFO. And this moves it over into the left atrium and out to the body, especially to the head and neck vessels. The desaturated blood, so the blood that's coming back from the superior vena cava, so the blood that's coming back from the head, this returns back about 35% in terms of its saturation, is preferentially directed downwards through the tricuspid valve into the right ventricle. So some mixing does occur, so ultimately you end up having sats of about 50% that go into the pulmonary trunk out the right ventricle. Again, most of the blood exiting the right ventricle passes right to left across the ductus, with really only about 8 to 10% of fetal cardiac output that goes to the lungs. Again, this is primarily because your PVR is high and you generally have a low vascular resistance of the placenta, which results in a lower SVR. So following birth, the onset of respiration in the lungs, expand and systemic oxygen rises, your PVR drops, and then the placenta is removed from the circulation, which increases your SVR. All of these promote pulmonary blood flow, increases your pulmonary venous return, and then ultimately you end up having a functional closure of that foramina valle. So in a normal infant, following this postnatal period, the ductus and the PFO close. There's no communication between the left side and the right side. And it's important to understand that one cardiac output, typically when we talk about cardiac output or full blood flow, we use the word Q. This amount of blood, if we break that Q into the pulmonary side and the systemic side, we should typically have a QP to QS of 1 to 1. And if that left to right shunting is greater than 1, we say that the QP to QS is greater than, there's more left to right shunting when your QP to QS is greater than 1. And then again, this would result with extra blood flow that goes to the lungs and extra congestion. While if we had right to left shunting, that would result with decreased QP to Q1 and you would result in cyanosis. So again, for the purpose of the talk, we're reviewing left to right shunts, where in all situations, the QP to QS will be greater than 1. So what are all the different types of left to right shunts? There's many ways, again, systemic blood flow can bypass the body and enter that venous system. When we talk about sort of intracardiac shunts, these are your ASDs, VSD, your AVSD, and then as we move to your extracardiac ones, your PDA, your AP window, AV malformations as well. And then the two other ones I skipped, the LV to RA shunt is a special shunt called a Gerbode defect, which again is a left to right shunt. And then you can also see coronary AV fistulas. So the direction of the shunt is, as well as the magnitude, is dependent on a couple of things. And the two big things are the size of the shunt, as well as the relative resistances to the blood flow on either side of the communication. And we'll review how that impacts when we talk about ASD versus a VSD. So from an ASD standpoint, when we look at the direction of the shunt, it's really dependent on the compliance of the ventricles. And so when we talk about sort of the compliance, we're talking about that relaxation or the stiffness. And during diastole, it's typically your LV end diastolic pressure is typically greater than your RV end diastolic pressure. And so you would preferentially see, if you did have an ASD, a left to right shunt, as the RV end diastolic pressure, the compliance is lower. In terms of the direction of the shunt for a VSD, as well as for PDA, we're looking at the relative vascular resistance on either end. And so in this case, when we're looking at during systole, when your AV valves are closed and your semilunar valves are open, what the ventricles are seeing are the relative resistances in the pulmonary vascular bed as well as your systemic vascular resistance. And again, usually your SVR should be much greater than your PVR. And so again, your typical presentation of a VSD would be left to right shunt. So how about the pathophysiology of left to right shunts? The increased pulmonary blood flow ultimately leads to clinical features of pulmonary edema, as well as abnormal lung mechanics. We're talking about lower tidal volumes, as well as lung compliance that elevates from expiratory airway resistances. And the mechanism is thought typically it's due to intravascular lung water. So when we talk about the transudation of fluid due to elevated hydrostatic pressures across those capillary walls, as well as you have an insufficient rate of lymphatic drainage, and all of these combined will ultimately lead to an increased extravascular interstitial lung water. In addition to the direct pulmonary effects, you also have neurohormonal activation, which occurs through things like your sympathetic system, as well as the renin-angiotensin system. So the distension of the cardiac chambers would lead to a ventricular stretch, which then would lead to a splanchnic renal and peripheral vasoconstriction. You would then have increased SVR, which then further increases left to right shunting, and then you start seeing the vicious cycle of a heart failure. In addition, there is upregulation of your beta receptors, which would then lead to tachycardia. You have increased renin-aldosterone, which leads to sodium retention, as well as vasopressin is released, which then leads to more water retention. And then you end up having an overall increased metabolic and oxygen demand, again, worsening that heart failure and then ultimately having end organ failure. So lastly, when you talk about the increased pulmonary blood flow, chronic exposure leads to elevated higher pressures, and then you end up having an evolution of pulmonary hypertension. This is really due to a medial hypertrophy of the pulmonary arteries. You have abnormal muscularization of those arterioles, and then ultimately a irreversible pulmonary hypertension. And the key pathophysiology of is really that chronic exposure to increased QP would lead to shear stress, and you have denuding of the endothelial cells of the pulmonary artery, which is a fairly small lining of cells. And so through that shear stress, you lose the endothelial cells. And that's important because you have, it's the source of all the endogenous nitric oxide as well as other vasodilator proteins. And so when you lose those, you lose the endogenous nitric oxide and the vasodilatory effects. So again, the process of pathogenesis, typically the phases as on that right side, you typically start with an abnormal muscularization of your precapillary arteries. You then start to have medial hypertrophy or thickening of the muscular part. You have loss of precapillary arteries, as well as you have neointimal formation. And then you have formation of plexiform lesions. And then finally, that sequela is again when PVR continually increases and ultimately gets higher than your SVR, you start to see, instead of left to right shunting, you would see right to left shunting and cyanosis, otherwise known as Eisenmenger syndrome. So the clinical manifestations, you can see tachypnea, again due to the extra lung water and the interstitial edema. You see tachycardia and diaphoresis due to increased release of catecholamines. Neonates can present with poor weight gain, again due to the increased metabolic demand and the myocardial oxygen demand. You have a higher risk of pulmonary infections and pneumonia. And then finally, again, you have a picture of a heart failure, all due to volume overload. So let's go through atrial septal defects. So I know we'll go through a little bit about embryology. And so the first steps when we look at how the heart, the atrial septum forms, you have formation of the septum primum, as well as the hole that's there is the ostium primum. And what you then have in the next phase is that ostium secundum begins to form by apoptosis of the original septum primum. So something to keep, remember this. But when you start to see apoptosis of that septum primum, that ostium secundum is what's really created. At the same time, you have formation of a septum secundum, and when the formation of that secundum is complete, you typically also see a closure of that ostium primum as that septum primum meets the endocardial cushions. And then you end up resulting in a flap where the foramen ovale is this one-way shunt allowing blood typically from the right atrium to the left atrium. So when we talk about the different types of atrial septal defects, there are generally 4 types. Here you can see the ostium secundum. You can see the sinus venosus defects, which are both your superior and inferior defects. And then you also have your primum defects. So the genetics of ASDs, typically, I won't go through all the details, but the boards love all the different types of syndromes. And these are the most common that typically get tested on. All again, from an ASD standpoint, genetics are a favorite. And when we talk about the most common ASD, which can be seen up to about 75% of them, is really your ostium secundum defects. I'll go through this real quickly, but your A is just a typical normal septal formation. When you see B and C are really your most common etiology of secundum ASDs. And this is all due to excessive resorption of that septum primum. I know it sounds confusing, but just remember that when you have the most common cause of a secundum ASD is due to excessive resorption of the septum primum. And so in D and E, this is when you have absence of the septum secundum, and this can also result in a secundum ASD. These tend to be on the higher side, and so again, you have the completion of the septum primum, but you just have the absence of the septum secundum, and you end up having a high ASD. And then finally in F, which is pretty rare, but you can actually have complete absence of the septum primum and the secundum as well, which ultimately creates essentially a common atrium. Primum defects, ostium primum defects, are usually due to failure of the fusion between that septum primum and the endocardial cushion. And this is commonly seen really associated with endocardial cushion defects, such as AV canals or AVSDs. And it's important to know that in AVSDs, the atrial defect is always a septum primum defect. Again, it's a failure of that fusion between the septum primum and that endocardial cushion. So when we talked a little bit about this, about the direction of atrial level shunting. And so during systole, if the atrial communication is large enough, the tricuspid and mitral valves are closed and the pressures immediately equalize. And so with no pressure gradient, there should be no shunting with the chambers. During diastole, you have the tricuspid valve and mitral valve open, and the ventricles, again, will start to fill. And depending on that compliance of the ventricles, the shunt direction is decided. So we were talking about this earlier, but in normal heart conditions, that compliance of that right ventricle is because it's a thinner walled and more compliant than that left, most of the time ASDs will shunt left to right. Again, in cases where RV EDP is elevated or the compliance of the RV is poor, you can see bidirectional shunting. Sometimes newborns can present with significant RV hyperplasia or some stiffness, so you could see some bidirectional shunting at that time. Again, as PVR also gradually declines postnatally, your RV compliance slowly increases, and this is again accompanied by an increased atrial left to right shunting. Thus, again, when you look at the natural history, most infants with ASDs do not usually present early in that newborn period. So how about the chamber effect on the heart? So atrial level shunts often result in enlargement of that right atrium and right ventricle. And although ASDs do result in increased QP, usually they don't present with pulmonary arterial dilation unless the volumes are significant. And again, because the RV dilates, the tricuspid ring annulus can also enlarge, and you can sometimes see worsened tricuspid regurgitation. You have volume overload to the RV, which again can usually be seen with interventricular septal flattening. This is typically seen in that diastole phase. And then when you think about sort of the flattening in systole, that would be more related to pressure overload. But in terms of the septal flattening and that enlarged RV, these can have some interventricular interactions that can result in mitral valve prolapse, as well as push the LV further and actually cause some LV obstruction, outflow tract obstruction. So how about VSDs? So the VSDs, it's helpful to understand that there are two broad categories of VSDs. And one of them is simple, what we always think about a ventricular septal defect, and that's just a deficiency of some portion of the ventricular septum. And the second one, which we'll go over, is a malalignment of the ventricular septum, specifically when we look at anterior and posterior malalignment. So VSDs, they make up 20% of all congenital heart disease. It is the most common lesion seen in trisomies. And VSDs, again, based on location, membranous and perimembranous are the most common. Typically, again, the membranous and small perimembranous area is a very small part of the heart. It's like the size of a pen cap when you look at neonates. The muscular portion is muscular VSDs typically are seen 5 to 20%. Inlet VSDs, again, near the inlet of the RV, so the tricuspid area, you can see 5 to 8%. This would also be in the posterior part of the heart and most commonly seen with AV SDs as well. And then outlet VSDs have kind of they have multiple names for it. So if you hear something about juxta-arterial, conal, supracrystal, or doubly committed, these are all lumped together as outlet VSDs, and those are, again, typically 5 to 7%. So here are the locations of the different types of VSDs. I'm going to show with my mouse over here. So here are your outlet VSTs. Again, when you're looking at this view, we're looking at it as if you were sitting or standing in the right ventricle looking towards the left ventricle, and the septum is in front of you. And so here you can see the outlet VSDs. Underneath there, you can see there's a small membranous area, and so that would be your membranous or your perimembranous VSD. Sometimes you can have a VSD, and if it extends out into the outlet or extends into the inlet portion, so that's how you can see how these can be commonly combined together. You have muscular VSDs, which are typically more in the trabeculated muscular portion of the RV, again, anterior, mid, as well as apical and posterior muscular defects. And then lastly, in the most posterior part of the heart, you can see close to the inlet portion, you would see inlet VSDs. So malalignment VSDs aren't a deficiency of the ventricular septum, but instead it's a defect within the septum as it's formed. The best picture, or the best way I always remember this, is that imagine if this is like back in the day when we were building the transcontinental railroad, and one side started in California and one side started in North Carolina, and somewhere in the middle of Oklahoma they came together and they realized that the train tracks aren't aligned. And that's like the best way to kind of picture in my mind about malalignment VSDs. So embryologically, again, the two muscular portions of the VSDs grow upward, and they're meeting with that conotruncal portion. And so when this doesn't meet appropriately, you end up having this malaligned defect. And so again, when I'm going to picture this in terms of like the relationship, I'm going to flip this so that we can actually kind of picture it like the way it is in the heart. And so if you can picture this across, you have typically the right ventricle is anterior and the left ventricle sits on the bottom. So it's in the posterior portion. And then you have the RV outflow tract into the pulmonary artery, as well as the left ventricle goes out to the aorta. And then here would be that septum in between that's separating the right and left ventricle. And so when you have a malalignment defect, if you have a anterior malaligned defect, the malaligned VSD will push that conotruncus here anterior, and you end up resulting in pulmonary stenosis. And so typically when you have pulmonary stenosis and a large anterior malaligned VSD, this completes the tetralogy of Fallot, and really it's a monology because it's the primary defect is really that anterior malaligned defect. So similarly, if you can think about, so there you go. So that a anterior malalignment would result in pulmonary stenosis as that conotruncus gets smushed. And similarly, if we did the exact opposite, where if you had a posterior malaligned defect, well, what would you see then? In a posterior malaligned defect, similarly as you're smushing the you see pulmonary stenosis, you would see a hypoplastic arch or coarctation. And so commonly, if you ever hear something about a posterior malaligned VSD, the first thing in your mind you should be thinking about is coarctation or hypoplastic aortic arch. Or vice versa, if you hear about hypoplastic aortic arch or coarctation, you should be ruling out a posterior malaligned VSD. So the consequence of left to right shunts at the ventricular level, so again, you have much more increased QP, both from the left and right ventricle. And what you end up having is, as that increased QP, you see dilation of the pulmonary arteries, you see much more blood flow going into the capillaries, you see the interstitial edema, and then all of this is coming back to the left side of the heart. So you see left atrial dilation, you see left ventricular volume overload and dilation as well. As this increases, you have LVH, you have the end diastolic pressure that increases. You have worsened LVEDP. This will increase your pulmonary venous pressure. Again, with that, as well as with the increased QP, you have multiple reasons why you could see both pulmonary arterial as well as pulmonary venous hypertension. And again, just to review the direction of ventricular shunting, during diastole, a large VSD is typically unrestrictive, and again, during diastole, you have equalization of the pressures in both the chambers, right? And so your semilunar valves are closed, your mitral valve and your tricuspid valve are wide open. And so with a large unrestricted VSD, you should typically see equalization of pressures between the two chambers, and there really shouldn't be any shunting. During systole, though, the mitral valve and the tricuspid valve close, and the pulmonary artery valves and the aortic valve open. And so depending on the relative resistances of the vascular bed, so in this case, the PVR versus the SVR, the direction of that ventricular shunting will occur. And again, we talked about typical pressures are much higher in your systemic versus your pulmonary vascular bed, and then this would result in a left to right shunt. So again, when you look at the chambers that are affected, this would typically be your pulmonary artery. You can see pulmonary artery dilation. You would see pulmonary venous dilation or increased pulmonary venous blood flow. You see left atrial enlargement as well as left ventricular enlargement. Okay. So now when we combine ASDs and VSDs, we can think about AVSDs. But the pathology of AVSDs are very specific, as well as specific to the different types of atrial defects we see, as well as the types of ventricular defects that we see. And so, in this case, in this picture, you can see a primitive AV canal connects to the atria and the ventricles. And the endocardial cushions make up the circumference of that AV canal. And typically, they're supposed to divide into a superior, inferior, right and left cushion. And so when these endocardial cushions don't develop normally to form two separate AV valves, it results in a endocardial cushion defect, or in this case, a AVSD. And so depending on the degree of the defect in the AV canal, you can see there are various forms of AVSDs that are created, and then really a spectrum of disease you can see it. When we look at the ways to categorize it, there are really four common ways to describe AV canals. Two of them are easy to understand, and the two of them can sometimes be a little tricky and confusing. So the two that are most common and I think are pretty easy to understand is the complete and the partial. And then the ones that sometimes people get confused about are the intermediate and the transitional. And here again, in a complete AV canal, we can start, and this is easy to know because you have one annulus with a large interatrial and an interventricular connection. Typically, again, your interatrial will be a primum ASD, and your ventricular will be a inlet VSD. And so, in contrast, if you look at a partial AVSD, in a complete AVSD, you typically see the physiology that's similar to a VSD and an ASD, right? But in a partial ASD, your physiology really is similar to an ASD, and the way the partial is that you have a septum primum defect, you don't have a VSD, and you have a anterior mitral cleft. And the key difference here between a isolated ASD, things to look at on an echo, you would see the level of the mitral and tricuspid valves would be actually at the same level, as well as the anterior mitral cleft would be a key distinction when you look at isolated ASDs versus a partial AV canal. In terms of the transitional defects, they're a form of partial AVSDs. Again, you have a small inlet VSD, but typically the leaflets of the AV valve effectively close that VSD component. And so you end up having a similar physiology to the ASD. And then intermediate, you have the inlet VSD and you have the septum primum defect. You also, key thing is that you have one annulus, but you have a ton of tissue that divides that common AV valve into a right and left component. And so you have you have two orifices, but one annulus. So the genetics of AV canals, this is, the boards will love to ask this question, and typically they can trick you, but it's sort of just the way you look at it. And, statistically about 75%, so 3/4 of patients with AV canals will have trisomy 21. So if you have a child with an AV canal, the chances of trisomy 21, it's very important to rule out by doing a karyotype. However, when you look at trisomy 21 as a whole, 40 to about half of them will have congenital heart disease. So similarly, if you have a child that's diagnosed with trisomy 21, it's important to do an echo to rule out congenital heart disease, since 40 to 45% of those will have them. And of those that do have congenital heart disease, about 40 to 45 will have an AV canal. And the one question that sometimes is tricky is that they'll ask you, what's the most common congenital heart disease in trisomy? And most people will jump at AV canals, but the answer is still VSDs. And so if you have a child with trisomy 21 who has congenital heart disease, the most common is still VSD. The last thing I wanted to mention about AVSDs is that complete AVSDs typically also can have an additional finding where you can see an elongated left ventricular outflow tract. And sometimes in echoes, you'll see something mentioned by a gooseneck deformity, or even just mention of an elongated LV outflow tract, because these would need to be followed up, because there is a higher chance of obstruction, as well as again, the key thing to look out for in those situations would be stenosis or obstruction. And so here's a cath picture of what the term gooseneck deformity would look like, as well as you can see on the left how the elongation of that LV outflow tract, again, due to the displacement of the AV canals, atrioventricular canal, annulus is not forming correctly. So the take-home points would be, again, the directionality of ASDs are related to the compliance of ventricles. The directionality of VSDs are related to the relative vascular resistances. Your VSDs as well as PDAs will typically result in left-sided volume overload, whereas ASDs, again, typically you would see right atrial and right ventricular volume overload. The risk, again, of pulmonary hypertension from left to right shunts are, again, through shear stress and loss of endogenous nitric oxide.